recording. Start.
Okay.
So, hello, good evening, you all. Myself, Dr. Himanshu Sharma. On the behalf of Team Physio Inculcator, I'm privileged to welcome you all on today's session. Today, we have a legendary physical therapist with us to talk on their expert topic, their expertise on the NeuroManual therapy, Professor Dr. Senthil P. Kumar, sir. We are really honored to have you with us on the board, sir. And we are even grateful to you that even though having so much of busy schedule, and you spared the time to share your incredible knowledge with us on the board to the participants. And so we are really grateful to you, sir, and much more thankful to you, and heartiest welcome to you on the board. I'm also thankful to all the participants. Many senior dignitary members are also joins us, and we are even grateful to Dr. Uma Sen Gupta ma'am also, that she also joins us today for this session. And welcome you, ma'am. Welcome all the respected participants, senior academicians, researchers, students, and my own teacher and mentor, Dr. Harsh Rajdeep, sir. So let me take the privilege to introduce Senthil, sir, as the name itself is much enough around the globe. But still, being a moderator, my responsibility is to introduce the resource person of the day, Dr. Senthil P. Kumar, sir. Senthil, sir, is a chief instructor at Academy of Manual Physical Therapy, and sir is having more than 17 years of the post-PG teaching experience, and sir had an experience of teaching in the various university of international repute like Manipal University, University, and Sharda University. And sir is also having an experience of teaching in the international university, and is also a member of Board of Studies, member of panel of examiner, and elite eminent speaker and a great researcher since last more than 1 decade. He has contributed a lot in the research. The words are actually not enough to introduce about their research expertise and their research interest. And he has been delivered around more than 150 lectures during this COVID pandemic, and he has presented their research papers and received the first prize in the paper presentation in around more than 20 international research papers. He has been published 255 peer-reviewed papers in a peer-reviewed journals, and he is the world's 13th most cited author on the manual therapy book in the Google Scholar, and has been conducted more than 120 workshops around the globe on manual therapy techniques and the numerous manual therapy techniques. And he is a great resource person, a great teacher, a great physical therapist, and a great researcher. We are really privileged to have you with us, sir. Thanking you from the core of my heart, and over to you, sir.
Thanks for that introductory placebo. Okay, because participants need to think that the resource person is a great person. You know, then only that placebo comes. Oh, we are going to learn something very great. Okay, so thanks for making me great for once. But I always believe that the greatness is depends upon how much good we do for others. Okay, any physio can become a best physio. Okay, being a best physio is not an achievement, that is individual. But if you have to be a great physio, make every other physio as the best. Okay, when you make everyone as the best together, you can be the greatest physio. The difference between best physio and great physio, best physio will be forgotten. After their death, only RIP will be there. Okay, but the greatest physios, people will miss that person and then try to imbibe the values of that person, okay, into life. Not only physio, even any kind of a great individual like Dr. Abdul Kalam, for example. We didn't stop with RIP. Okay, we are seeing his thoughts every day now. okay, after his death also. So that is how we keep living the legends to live within ourselves, okay, rather than missing them as human beings, okay. So good luck to all of you. I'm going to take a concept today, which is, you would have heard it as nerve mobilization, okay, commonly, which is under David Butler, mobilization of the nervous system. There's a textbook. So he popularized it as neural mobilization. And then Michael Shacklock, the other, his junior, David Butler's immediate 1 year junior, he popularized it as clinical neurodynamics. I repeat the word neurodynamics, okay. The difference between Butler and Shacklock, Butler told about stretching the nerve, okay. We can elongate the nerve. Like imagine if this is the nerve, okay. If I pull it from both the ends, you can see that it will get elongated. The diameter narrows, okay. The diameter which is like this, when I am pulling, it becomes thin, okay. What is called as the tension techniques or tensioning techniques of the nerve. Typically an example, when I bend my neck to my right side here, okay, and then I do a shoulder abduction 100 degrees, okay, and then external rotation maximum, supination, wrist and thumb extension, and then I do an elbow extension, okay. When I do this, I'm actually trying to pull the full brachial plexus, okay. When you are doing with me, for example, if you are also trying to have this experience, bend the neck to the opposite side to that upper limb, abduct, externally rotate, supinate, wrist extension, and then elbow extension. You will start feeling the stretch sensation in the forearm. You might start feeling in the thumb. If you are maintaining it beyond 10 seconds, you might get some numbness in the hand also, okay. But the point is, we are elongating the nerve. How do we know that the nerve is getting stretched, not the muscle? Yes, in the numbness is there in the hand. When I bend to same side, the numbness is reducing. When I bend to the opposite side, the hand numbness is increasing. So that means the symptom is there in the hand, okay, but I am moving my neck, which is far away. If I am moving the wrist, my forearm muscles will be getting influenced, okay. So I don't want to influence the muscle. I want to influence only the nerve. That means I should move a part which is far away from that region. In a patient who gets neck pain, okay, during this supination, wrist extension, and then extension, and if the patient is getting neck pain, okay, don't try to move the neck and see whether the stretch sensation is reducing. You will see it by wrist flexion extension, whether it is altering the neck pain, okay. So that means you are moving a region or a joint which is far away from that region where the symptom is present, okay. So what I demonstrated now was originally called as the brachial plexus tension test by Robert L.V. and later it was upper limb tension test 1 by David Butler, okay. And after David Butler, the tension term, okay, that elongating the nerve was more common in David Butler's mobilization of nervous system. Michael Shacklock, he was not fond of elongation alone. What he told was, if you feel that stretching the nerve will be making it better, no, some patients will have worsening of symptoms. People may not improve with tension techniques. Okay, everyone cannot tolerate the stretching of the nerve. Even when you might have done that with me, you might have felt it is very discomfort and immediately you might have lowered the arm. Okay. So what he told was, there should be another kind of mechanics in the peripheral nerve where the nerve is not stretched. Okay, it is not stretched, but it just moves from one region to another region. Okay, which is called, he mentioned it as sliding. Okay, the nerve is sliding on the under surface. Okay, so it is sliding like this. So that is a slider. Okay, sliding dysfunction and the slider. And he proposed that how we can involve sliding of the nerve. Okay, remember that this is like a tug of war rope. Okay, rope in the tug of war. So there's a team of people, 4 people pulling this side, 4 people pulling this side. Okay, if both are pulling, what will be the effect? Tension. Okay. So if both are pulling means tension effect comes. But if one is weak, another is strong. Okay, this is strong, this is weak. So what will happen? Pulling time, it will move towards the strong side. Okay. So that is, it's sliding towards the strong side. Okay, the pull. And the same way, if this is strong and this is weak, okay, there's only one and this is two people are pulling. That means what will happen? The nerve move towards the strong side. Okay. So this mechanics happen in the same example which I demonstrated. Okay. Neck is there. It is pulled at the neck. When I extend the elbow, it's pulled in distally also. Okay. So if I am doing like this, so what is happening? Okay. Both the ends, the pulling is happening. So it goes for a tension technique because I am extending the elbow also and I am laterally flexing the neck also to opposite side. Okay. So this creates a tension effect. But instead, if I synchronize my movement in such a way where I bend to opposite side in the neck and I flex my elbow, okay, I don't extend my elbow, okay. So the elbow is the weaker side. I don't pull from the elbow. The pulling is from the neck, okay. And then next one, I pull at the elbow, but the neck is relaxed, okay. So I do this. So what happens to the nerve? Can you see that? Okay. The nerve is not getting elongated, but the nerve is moving proximally here, moving distally here. Okay. So that is the movement of the nerve, which is called as the slider. Okay. And Michael Shacklock, that's why he termed it as neurodynamics. We are not just to produce tension in the nerve, it's dynamics of the nerve. And Michael Shacklock, this Butler was so curious to somehow improvise his concept. Okay, mobilization of nervous system. So what he did was, he introduced that you take your arm, for example, okay, in the middle of the arm, in the middle of the biceps, you just feel with your one finger, don't give too much of pressure. When you are percussing like this, okay, you might feel other areas when you are tapping, you will just feel the tapping. Here also just a tapping. But particular area when you tap, you will find some kind of electrical sensation. Okay. If you want to feel that electrical sensation more specifically, medial epicondyle is the best example. Okay. When you tap here in the medial epicondyle, you will feel that electrical sensation in the little finger. Okay. That's nothing but the ulnar nerve, which is posterior to the medial epicondyle. Okay. Same way here, median nerve comes right in the middle of the arm and the forearm. Okay. So exactly in the middle of the arm. So where I am keeping the finger, okay, that area when I keep, and after that I open and close my finger of the same hand. Okay. So when I am doing this forceful pumping motion, okay, finger movement only I am doing. I am not moving the elbow. I am not moving the wrist. Okay. But you will find in my arm, there is a movement here. Okay, can you see the finger? My finger moving and the arm moving. It's nothing but it is the median nerve which is moving. Okay, the median nerve is influenced by the finger movements, especially thumb and the index. Okay, and if you want to feel ulnar nerve movements, medially you have to palpate. Okay, so medial arm, and then you do the fingers, especially little finger and ring finger. Okay, you can palpate the ulnar nerve in the arm. Okay, so you can feel that under your finger here. You can also palpate it easily in the medial epicondyle. Okay, and posterior. This is medial epicondyle, so posterior. So you'll feel a thread-like structure. Okay, which will be like snapping under your finger. Okay, when you are palpating, the nerve will go side. It won't stay under your finger. Okay, it is not like it will say that, yeah, I am the nerve. Okay, it's very sensitive to palpation, so it will always move. Okay, and when you move the neck, or when you move, for example, even when I am palpating in the forearm, okay, that is the median nerve, middle of the forearm means. If it is medial side of the forearm, from flexor carpi ulnaris to the pisiform, okay, that is the ulnar nerve. Okay, So when I am palpating, when I move the neck, I will still find the movement of the nerve in the forearm. Okay. So nerves are detectable by palpation. So Butler said there can be tenderness of the nerve. Okay. So like muscles are tender, ligaments are tender. When you palpate, they become producing pain. Same way, nerve also can produce pain upon palpation. Okay. This is also part of what is called as mechanosensitivity. That means ability to produce the pain or sensitive to painful stimulus, which involves mechanical stimulus like movements or pressure. Okay. So both will be sensitive there. And what happens in this situation is when you do a tinel sign, I can percuss at the brachial plexus in the scalene thoracic outlet, come to the pectoralis minor. And if I want a median nerve percussion, I can percuss in the arm, forearm, okay, and then come to the thenar muscles and then go to the lateral digital branches, okay, which supplies the lumbricals. So this is a median nerve distribution. I am doing what is called as a tinel sign, T-I-N-E-L, okay, tinel sign. In carpal tunnel syndrome, where there is a compression of median nerve in the flexor retinaculum at the wrist, okay, when I tap here, sometimes numbness will come in the thumb, okay. So that means I am tapping at one location, but numbness is coming distally, okay. Another situation, pronator teres syndrome, okay. Pronator teres syndrome is also entrapment of the median nerve. There also when I am tapping, sometimes you may not get thumb numbness, but you will get numbness in the forearm, okay. So that means you are tapping at one location, there itself you are getting numbness, which is called as local positive tinel sign, okay. Locally positive tinel sign. That means when you are percussing, you are having numbness or pain in that region of percussion. Distally positive tinel sign. That means you are percussing at one location, numbness or the burning sensation is coming distally, okay, somewhere far from that area of percussion. Distally positive tinel sign is important. It shows that the nerve fibers have got damaged, okay. There are in partial injury and regeneration is happening, Valerian regeneration. And because of that, when you are tapping, excessive stimulus, ectopic discharges happen in the nerve. So distally, the numbness is felt, okay. In that scenario, what happens is you should treat like in presence of a fracture or a muscle injury, you don't do massage, okay. Same way, why? Because it will cause myositis ossificans, okay. In fracture, if you do massage or when you do hemorrhage, hematoma is there, muscle fibers are torn, you do massage, okay. Fibers cannot heal. You want it to allow that to heal. Same way, nerve massage is contraindicated at the area where the nerve injury is there, okay. So how do you know the nerve injury? When we percuss with the tinel sign, distally symptom will be there, okay, distally, not at the region of percussion, okay. That's the first point. And in that situation, the nerve injured nerve, that region, don't give the nerve massage, okay. You will do the nerve massage distally or proximally. Proximal segment, you can do massage, okay. Nerve massage. Nerve massage means massaging along the course of the nerve, okay. You can do massage in terms of longitudinal nerve massage, okay, with my 2 fingers, okay, longitudinal nerve massage. This is a longitudinal nerve massage to the median nerve, okay. Imagine that the pronator teres syndrome is there, okay. Here, regeneration is happening with the nerve damage. So I'm getting numbness, okay, when I am percussing here. That means I should not do nerve massage here, okay. That is at the elbow or the forearm. So I'll mark it. So that this is the region which I am getting positive tinel sign, okay. So this region, I should not do the nerve massage, okay. So proximal area, I will do it proximal direction, okay, like this nerve massage. Distal segment, distal to the area where the tinel sign was positive, okay. Distal direction, I will do the nerve massage, okay. So proximal segment, I'll do in a proximal direction. Distal segment, I'll do in a distal direction. I am offloading the injured area, okay. So that's the principle of nerve massage, which was described by David Butler, okay. And then further what happened, Shacklock, he introduced very extensive level of examination, he said that all patients will not tolerate the full loading, okay, till the last end range. Some patients may have numbness in the hand only with wrist extension, okay, or some patients carpal tunnel syndrome, but only neck you move, they will get the numbness in the hand, okay. So severe damage, if the nerve is very severely sensitive, single component itself will lead to the symptoms, okay. That is level 1 examination. Level 2, the full component of the testing, okay. Level 3, you are combining it, it's like maintaining it for a longer time, okay, or you are giving a contraction, okay, together with the what is called as the neurodynamic position, okay. You are giving contraction, you are giving compression, okay, to the joint, you are giving a glide, okay, in that neurodynamic position. That is level 3 of examination, okay. So it is like he tried to categorize patients depending upon their severity of presentation, and he expanded the examination. That is neurodynamics, Michael Chekala, okay. Finally, Butler wanted to do something extra. Why I'm telling between these two? Because there is a huge competition, okay, between these two, okay. David Butler, what he did was brain, okay. Everything is not peripheral. Central nervous system also can cause neural pain, okay. So what he did was, it is like you can go ahead with what is some identifying some patients who have chronic pain. Why they have chronic pain? Because past experiences with pain. I keep on having back pain 2-3 times. Then after that, the brain has a memory of pain, okay. That previously I was sitting for half an hour, it was paining. Last 1 week back, 10 minutes sitting itself, it is paining, okay. So the representation of the back region, lumbar spine in the brain is replaced by pain, okay. Cortical representation of pain, okay. Pain plasticity. We have plasticity for functional activity, we have plasticity for functional recovery, okay. But pathological plasticity is also there. If you get a disorder in the brain, abnormal movement, and abnormal movement will be represented there, and the patient will be doing the abnormal movement only, okay. They won't be able to pick up an object. They will always go with the synergistic pattern, okay. This happens in upper motor neuron disorders. But here there is no brain injury, okay. There is no structural problem in the brain. It's only neurotransmission, where the amygdala, okay, there are various nuclei that are present in the brain, which is called as neuromatrix, okay. So it's a complex network. Neuromatrix of one person and another person will not be the same. It depends on my own habits, my personality type, okay, my previous experiences with the pain. And because of this reason, the brain itself will maintain the pain, okay. There is no abnormality in the nerve, there is no abnormality in any of the structures in the extremity, but the symptom will be perceived by the brain, okay. So that is central mechanism of pain. And Butler and Lorimer mostly, they explained it as, obviously, explain pain, okay. And then they devised that some therapies like pain physiology education and also graded motor imagery, okay. To best understand a central mechanism, you remember that the people who are amputated, okay, the hand is removed because they had a gangrene, okay, severe burning pain, sleep disturbances in the thumb, okay, subject is telling amputated, okay. It's a below elbow amputation. But after 1 month, the subject feels my left thumb is burning. Left thumb is amputated, okay, there is no thumb at all. The patient feels that pain. It's called as phantom limb pain, okay. Why that phantom limb pain becomes? Because the suffering of the pain experience memorized and represented in the brain, okay. So that's why we feel the pain even if the part is not there, okay. Now recent research has concluded that not only in fibromyalgia, not only in what is called as chronic fatigue syndrome, okay, a lot of other systemic disorders are there. Other than that, musculoskeletal disorder also, central sensitization and brain involvement is there. The pain is maintained by the brain. So sometimes people are given what is called as brain gym, okay. You might have seen some apps where we can train our calculation, colors, okay, simple problem solving, all this. When we do that, our brain, rest of the areas become active so that the pain area shrinks. Okay, the other areas take over. Okay, so that happens also during music therapy, during meditation, prayers, for example, because some people pray God and they walk on the fire. They don't get the pain in the foot. Foot is burnt. Okay, skin is burnt, but they don't have any pain in the foot because they have strong descending inhibition. Okay, because of the central mechanism that they are able to control that pain. Same way, brain can produce the pain also and use the pain also. Okay, so it's a very amazing concept. So Butler evolved like this. Both of them, Butler evolved the Neuro-Orthopedic Institute, NOI, okay, NOI group. And Michael Cheklock evolved the neurodynamics, which is called as the clinical neurodynamics, neurodynamicsolutions, okay, .com. And both of them certify the practitioners and the instructors all around the globe. Okay, we have Dr. Prakash Sharoff from Mumbai, who is actually certified for the NOI group, Neuro-Orthopedic Institute, under David Butler. And then we have Dr. Kiran Challagundla, okay, from Hyderabad, who is actually certified in the neurodynamics, okay, as the certified instructor. With due respect to all the certified practitioners and the instructors, what typically happens in a clinical scenario? I am a certified McKenzie practitioner, okay? Then what do I do? A patient comes, Himanshu, okay? What do I do? Whether Himanshu has a clinical presentation that indicates McKenzie or not. My focus is only that, okay? I check the patient, I have all the findings, but finally I like to think whether I can use the McKenzie on him or not, okay? Because I am a certified McKenzie practitioner. I am supposed to use McKenzie on everybody, okay? I have to select the patient. I am selecting the patient for the technique, okay, as a certified practitioner. And if I am a Mulligan practitioner, then immediately what I will do, I will check if the patient is suitable for the Mulligan concept. Okay, that means I am selecting the patient for the technical end. Again, this is a technique-centered approach. I felt the need that we need to have patient-centered approach. Okay, we can't have technique-centered approaches. So what we need to do, the reverse, select the technique for the patient. Okay, don't stick with one technique. Okay, combine all the techniques, give one technique more than the other, okay, but integrate all the techniques so that you can give the best to every type of patient you can treat. Okay, there is no question of contraindication and making sure that people always gets benefited, patient-centered approach, okay, where we select the techniques for the patient, individualizing for each and every patient, okay. So along that approach, I combined the neurodynamics and the neural mobilization into NeuroManual therapy. So 2010, I wanted to register the NeuroManual therapy, NMT, as a separate approach, which led me to form Academic Manual Physical Therapist, which is AOMPT. Okay, so it's such a wonderful concept, and most of the times technique-centered teaching, they teach what is called as what are the anatomy, okay, what are the biomechanics, and then they go to what all examination you can do and what are the techniques for examination, what are the techniques for treatment, okay. And if you ask them for cervical radiculopathy, what can we do, okay, they will tell that you check the ULNT 1, 2, 3, 4, okay, whichever is positive, and you see that whether it is a sliding problem or a tension problem, then you can give the slider or the tensioner. This is a blunt answer, okay. They won't answer you with clinical related ones. For example, I'll tell you, in a patient-centered approach, we start with symptoms, okay, chief complaint of the patient. From the chief complaint of patient, how to know that there is a neural involvement. And then next one, subjective examination. We ask the patient, what are your experiences with your symptom? What aggravates your symptom? What relieves your symptom? Whether the numbness is there, or is it the pulling sensation is there, or tingling is there, okay, or pins and needle sensations are there, okay. Is it like burning sensation? Is it like you feel heaviness of the hand, or you feel like light, the hand is not there, okay. All the sensations, okay, chief complaints, and try to see that whether it is only neural or neural with vascular, neural with muscular, okay, neural with articular, any combination can come because it is patient, it's a human body. You don't think that only nerve will be affected, okay? Just because I am a certified NMT therapist, I should not think that everybody is having nerve problem alone, okay? So I should know that they are all human beings. Every structure is, they are trying to, you know, fight the abnormal forces, and in that bargain, they become symptomatic, okay? Homeostasis. So that approach, symptom, subjective examination, then objective examination comes, which is related to the symptom of the patient, okay? For example, in a patient who is having radiculopathy, cervical radiculopathy, it's a compression of the nerve root. The primary pathology is foramen narrowing, okay? The intervertebral foramen is narrowed and there is a compression of the nerve. So the point is, facet joint osteophytes can compress, intervertebral disc, nucleus pulposus can herniate and compress, okay? From anterior there can be compression, from posterior also facet joint can get compression, okay? These two are probable compressions. And then the next one, the nerve. Sometimes nerve will get inflamed, enlarged, okay? Radiculitis, okay? They tell inflammation of the nerve root, okay? So that can happen either metabolic or it is because of toxins, okay? What is there in the body, maybe drug induced. That also can cause radiculopathy because if nerve is normal, tunnel, it is normal movement. If nerve is enlarged, compression will come, okay? Similar thing happens in pregnancy and myxedema, people developing carpal tunnel syndrome. There is no problem with the lunate, there is no problem with the flexor retinaculum, but the median nerve becomes larger, okay? Fluid retention within the nerve. So that causes the compression effect, okay? So either it can be pathologies of the nerve or pathologies outside the nerve, okay, which can create the compression effect, okay? And the neuropraxia, initial compression, might progress to a partial injury, which is an axonotmesis, or a complete injury, which is a neurotmesis, depending upon the duration of compression or the severity of the compression, okay? So lot of factors involved in that nerve injury and that regeneration and the progression, okay, which we see in a clinical scenario. So now what are we actually trying to approach is from the patient perspective, okay? So get the symptoms of the patient. Some patients will tell, I am walking, then after that I am having numbness, okay? So that means you know that it is stenosis, okay? Lumbar canal stenosis, and then there is a numbness in the foot, or piriformis syndrome and then numbness in the foot, okay? Or hamstring syndrome and then numbness in the foot, okay? Or lower leg compartment syndrome and having a numbness in the foot, okay? So always remember that diagnosis, okay? Where levels the numbness in the foot can come after walking, okay? It's not like anatomically you are going to influence the nerves. You are going to treat the nerves so that functionally the patient has to become independent and improved quality of life, okay? So that's where we need to combine. And also there are other techniques in manual therapy, like I was telling you about joint mobilizations and myofascial releases, okay? So these myofascial releases can also be done together with the nerve. And there are positions like, for example, this is the loading position, okay? This is the loading position of the ULNT 1, okay? Upper limb load and mid test 1. Opposite of this, extended wrist is there. I flex, okay? I pronate the forearm. I flex the elbow, internally rotate the shoulder, okay? Adduct the shoulder, okay? And bend to the same side. This means that I have offloaded the brachial plexus, okay? The initial ULNT1 test, the end position is a loading position. Opposite of that loading position is offloading, okay? Offloading, OFF, okay? So every nerve has an offloading position and a loading position. And constant symptoms, okay, have disturbances. They are not able to do anything because of the pain, okay? Just maintain the offloading position for 3 minutes. They'll feel, yeah, now my numbness is reduced, okay? Or even you keep a cold pack, okay, along the course of the nerve, or you keep a high frequency tense, the burst tense, you keep it, okay, in the distribution of the neural symptoms. Still you will have drastic relief, Okay, this happens in patients who have constant symptoms with spasm. Okay, offloading, and you can do that. You can also do a positional release for the trigger points in the upper trapezius, or do a myofascial release as tolerated by the patient. Okay, in the offloading position. That means neural positioning is done. You are using a myofascial manual therapy. Okay, it's not that you are stuck to only nerves. Okay, you are not treating only the nerve. You have to treat the muscle also. And sometimes, in the example of radiculopathy, which I was telling you that neural position is there, I can also give a traction. Okay, sitting traction. I can fix the halter sling, give the traction. With the traction, do the neural. Okay, because there is a compression which I have to relieve it. Okay, so remember that. Don't be technique oriented. Be patient centered. Okay, so this led to this concept, and I had my confidence, my initial source of inspiration from treating more than 140 diabetic neuropathy patients. Okay, I have treated in my research work at Manipal University. Okay, so after that I got the confidence that we should combine. First, you can give contrast bath if the patient is having vascular issues. Later, you give what is called as nerve massage, as indicated by the Tinel sign. Remember, locally positive or distally positive. Okay. When it is locally positive, okay, second presentation, think that it is like a scar. Okay, scar in the nerve. Okay, so there is an adhesion in the nerve. So that does not indicate, contraindicate nerve massage. Okay, so when I am focusing on elbow and if it is positive, I can immediately keep the fingers on the median nerve, keep the thumb on the opposite side, okay, like this. And then from my shoulder, I can do the movement so that in my forearm, I will get a transverse massage to the nerve. Okay. So this is transverse massage, which is important to relieve the adhesion. Okay, the scarring nerve with the muscle. If there is adhesion is there, you have to mobilize the nerve mediolaterally. Transverse massage. After that, longitudinal massage, I will do full length. Okay, so I will not do it distal towards distally, proximal towards proximally. Okay, because there is no injury there. There is only a scar. After that scar is mobilized, transverse friction, I will do full length longitudinal nerve massage, preferably distal to proximal. Okay, and when I am doing full length, have the presence of mind similar to the manual lymphatic drainage. Okay, what do we do in manual lymphatic drainage? First, drain the area in the arm. Okay, why we drain the proximal segment is because if that is free, then only from middle segment to proximal you can go. Okay, if you don't drain the proximal, there is no point in draining middle to the proximal. Okay, it will not go. Okay, so that's why first you drain the proximal, make it empty. Okay, then middle to the proximal. Okay, after that distal to the middle. Okay, this is what is manual lymphatic drainage. The same principle, there is a lymphatic circulation to the nerve also. So what you have to do is, for the nerve also, any segment, if it is only the arm, okay, if you want to give median nerve massage, that means proximal segment you give longitudinal nerve massage. After that, middle to proximal. Okay, now middle is empty. After that, you do the distal to middle. Now what has happened is distal has become empty. Okay, and now proximal and middle are there. Okay, distal only is empty. So what you do, again drain the proximal. After that, drain the middle to the proximal. Okay, now middle has become empty together with distal also being empty. Okay, but only proximal is there. So last cycle, you will do the massage to the proximal. So after that, what will happen is the whole segment median nerve in the arm, you have cleared with longitudinal nerve massage. Not with a single stroke throughout the limb. Okay, you will do dividing into 3 segments. Okay, you can divide into as many segments as you can. Okay, individualizing according to the patient's clinical presentation. Some patients may have Tinel sign positive at 2 locations. Okay, so or you might have compression of the nerve at 2 locations. There may be radiculopathy and there may be carpal tunnel syndrome, what is called as double crush syndromes. Okay, so you need to know whether initially a patient had neck pain or initially the patient had numbness. Okay. If numbness in the hand was first, 6 months before I had numbness in my hand, last 1 month I am having neck pain. That means obviously carpal tunnel syndrome is first, later it is radiculopathy. Okay. Or another patient tells 3 months before I had neck pain, but now last 1 week I am having numbness in the hand. Okay. So you should suspect radiculopathy was first and carpal tunnel syndrome is later. Okay. And to palpate the nerve, the knowledge of surface anatomy, the course of the nerve is important. Okay. And when you are treating the nerve using sliders or tensioner techniques, I demonstrated the slider. Okay. For example, if I am doing from here, okay, like this, elbow extension, neck is bending to same side. I will not feel any kind of stretch here. Okay. Because it is just sliding distally here, sliding proximally, because proximal is pulling, neck is pulling. This is relaxed. But the same, if I'm doing like this, it's pulling at both the ends. Okay, so it's a tension technique. Okay, so tension technique may be useful in later stages of rehab, whereas slider techniques are useful in the beginning of rehab. Okay, in this also, I can keep the neck bent to same side, relaxed in the neck, and then do this. Okay, what happens is it slides only distally. Okay, there is no sliding proximally because there is no movement in the proximal. Okay, and if I want a distal tensioner, keep this loaded. This becomes distal tensioner. Okay, if I offload, distal slider. Okay, if I load, distal tensioner. Okay, and the same way, elbow is offloaded. This is a proximal slider because this is offloaded. Okay, it slides proximally. Whereas elbow is loaded, proximal tensioner. Okay, I was showing you this. This is a two-ended tensioner. Okay, both the sides we are producing tension. Okay, tug of war. And then what we do this distal, this is proximal, distal, proximal. It's a two-ended slider. Okay, so in the treatment protocol, two-ended sliders are first. After that is distal slider, then proximal slider. Okay, you can note down also. So two-ended slider is first, next is distal slider, next is proximal slider. Next you will create distal tensioner, then proximal tensioner, and last is two-end tensioner. Okay, so distal is first, then proximal comes in slider also and tensioner also. Okay, so two-ended slider is the safest technique for everyone. And after that you will give the distal slider. Next you give the proximal slider. Okay, and after that you add the tension techniques, which is distal tensioner and then proximal tensioner, and last is the two-ended tensioner. Okay, and combine at every stage with other manual therapy techniques of myofascial release, or you can even involve cupping. Okay, along the nerve, the course of the nerve cupping, and then you can do the movements, neural mobilization, or you can also involve kinesiotapes. Okay, so try to see that the mechanics is more important. It's not the technique. Okay, and how can relieve patient symptoms in NeuroManual therapy. After the extended summary, which I wanted to clarify for the NeuroManual therapy, I'll go to the presentation. I run through the slides for people to know a bit of theory and some kind of wordings and attractive pictures. Okay, and so we'll see the slides. But before we move to the slides, I request all of you, those who are actually willing to get certified for this webinar, please contact me and answer a small quiz to get the certificate. Okay, and the next one, of course, there is a video course. Okay, extensive video course. Both has CNMT, okay, certification in NeuroManual therapy. Among these participants, Dr. Harsh Rajdeep, okay, sir was there. Sir is also now also there, okay, attending. Sir has completed the CNMT at Gwalior. Okay, when I was honored to to have your friends learning from you. That is when you really feel you are doing best for the profession. Otherwise, what is the use of friendship? Okay, people should first learn. Okay, So that's what I feel. And Dr. Harsh is some leading example. Okay, is an inspirational role model and a professional icon. So sir attended the CNMT. The same CNMT is available as video course also. Okay, including disorders and conditions, how you can use NeuroManual therapy. Otherwise, a simple level, you want to learn the neuromobilization, best applicable clinically, how you can use. You can opt for the 22 videos NeuroManual therapy course. That is also video-based courses there with the certificate, okay, from the AOMPT. So, as you are contacting me on my WhatsApp, which is 80599342234, okay, the mobile number 8059923342234, okay, 80599342234, and make sure that even you put my name or you put AOMPT, you will always get that number only, okay. And I don't think any one of you who is attending now do not know my number, okay. So you can note down, contact me. You can do that course. The videos are practical demonstration, explicit teaching, okay. You will really feel like you are attending a direct workshop when you are watching those videos, okay. So that guarantee is there. And don't miss learning this approach, which is patient-centered. I don't want a technique-centered paradigm, okay, where certified practitioners, certified instructors, okay, so many are there. Remember that for us, neurodynamics is better or neural mobilization is better. No, okay, we are not bothered about the politics. We want the patient to be better. So combine both and use it clinically, okay. So that should be the main goal of a clinician, okay. Then only you are a clinician. Otherwise, you are a technician. Okay. Even if you prefix doctor also, if you are running behind techniques means you are a technician. Run behind the patient. Run behind the clinical presentation of the patient. Okay. Try to select the techniques for the patient. Then you are a clinician. Okay. If you treat the disorder, you are a physician. Okay. If you treat the symptom, you are a technician. Okay. If you treat the patient, you are a clinician. Okay. So rest is definitely, you know what is best, and make sure that you are on track, and also make sure that everybody around you, your knowledge, okay, everybody. This lockdown has given huge opportunity that we came to know each other across geographical boundaries, and it really helped a lot. It's a great thing that I always thank Corona and COVID-19. Okay, I'm not afraid of Corona. I'm thankful to Corona. Okay, that we all came to know each other. You are enjoying the session in the late night. Okay, otherwise normal college after that. When will you ever imagine that 10 o'clock you are attending a webinar? Okay, you are listening to a guy in a very colorful shirt. Okay, where Dr. Himanshu was introducing so much big. And still you are able to enjoy it. Okay, because morning 9 to 10 itself, physio students, we feel sleepy. Okay, so night 9 to 10 also still you are learning. It's because of the lockdown only. Okay, if there is no lockdown, there is no value. Okay, so coincidentally, AOMPT is most sought after. Everybody is learning. I'm happy that AOMPT could do the things the best during this lockdown. Himanshu said 150. Actually, AOMPT has conducted more than 300 webinars this lockdown. And so it's a great thing apart from the numbers, okay, is the change that you can get as a therapist, okay, as your self-image, and also for the future, how you will be responsible to make others the best, okay. So that much. So without taking more time, I will go to the presentation once I message my number in the chat. Okay, just people are asking that. Already, Dr. Himanshu has messaged my number, but our physios will never see that. Okay, even in the poster also there is a mobile number. Still, everyone will ask, sir, how to register? Okay, so that's anyway. That's the greatness of India. Okay, we always want ourselves to be pampered. Okay, so go to the presentation. Yeah. So we are ready to see the foundation principles of NeuroManual therapy. Okay, where remember for every nerve there is a different positions. Okay, for ulnar nerve the position is like this, and for the radial nerve it is with the wrist flexion, and then it is with the abduction. And you have factors which you can monitor and evaluate during your clinical approach. Okay. So NeuroManual therapy is a patient-centered clinical approach to recognize both central and peripheral mechanisms, and then administer nerve palpation and massage, nerve sliders and tensioners in offloaded position or in the loaded positions to integrate articular, myofascial, okay, all the techniques along a biopsychosocial model. Okay, the definition looks big, but remember the theory, as much it is complex it looks, clinical approach is much more simplified. The challenge of why AOMPT everybody prefers to learn is only because of the ability to make things simple. Okay, so identify the nerve related pain and also mechanosensitivity of the nerve through the neurodynamic testing, nerve trunk palpation, okay, and tunnel sign. Remember that there are some findings like psychosocial maladaptive behavior, abnormal beliefs and behaviors which will indicate an yellow flag, whereas the involvement of the spinal cord, okay, malignancies, infections, fracture dislocations, all of them will be red flags, which will indicate, red flags will indicate referral to physicians for investigations. Yellow flags will indicate psychosocial interventions. Okay. So regular neurological examination, clearing the sensory deficits, and also the muscle testing for the motor deficits is important because these are considered as negative symptoms if there is a nerve damage. For tunnel sign, two people were involved in forming that, Paul Hoffman and Jules Tunnel. Percussion of the nerve, so locally positive versus distal positive. Okay, and the palpation of the nerve along the course. You know the grades of tenderness. Okay, so in musculoskeletal system we have 0, 1, 2, 3, 4, the grades of tenderness. Okay, grade 4 tenderness is patient will not allow you to touch. Okay, and the grade 0 is absolutely no tenderness to whatever deep you palpate. Okay. And the principles of the testing, remember that including the facial expressions, communication, sequence of components. Okay, check whether the numbness comes in the initial range or in the end range. Okay, end component last, because it will indicate a sliding dysfunction versus a tension dysfunction. And then you see that you can differentiate it, and also don't hold the position beyond 10 seconds. If at all you hold by mistake, don't hold beyond 30 seconds. Okay. So always test the normal limb first, then come to the affected limb, although many of us don't follow that. So different components for upper limb neurodynamic test 1 for brachial plexus. Upper limb neurodynamic test 2 is for the median nerve, where it is the same component as the ULNT1, but the shoulder abduction is last. Okay. And ULNT3 is for the radial nerve, where wrist is flexion and the internal rotation components are there. Okay, mainly. In ULNT4, it is the ulnar nerve, which is the only test which involves elbow flexion. Okay, because ulnar nerve is loaded with elbow flexion. And categorize the patient into high irritability, moderate irritability, or the low irritability, and then give the nerve sliders, okay, preferably in the beginning of the treatment. Then progress from offloading to loading. Transverse massage is first, then longitudinal massage. Start a region which is far away from the symptom. Okay, you can treat the right side by using the left side neurodynamics. Okay, or you can treat the right upper limb with the right side SLR or the left side SLR. Okay, lower limb also. So don't that nervous system is a single structure. Okay, connected, interconnected all over the body. And also don't forget the active component to train the muscles for stability and muscle control. So that's David Butler, and you can see that logo of the NOI group. Okay, and here we have Michael Sheklock with the Neurodynamic Solutions, their logo. So center we have Lorimer Mosley. And so the session I would like to dedicate always, remember the NMT alone as a workshop, I have taken more than 65 workshops, okay, on NMT, NeuroManual therapy. And as webinar alone, during this lockdown alone on NMT, this foundation principles which I am taking today, it is my 13th webinar, okay. So I have taken this, and also 10th year anniversary of NMT, okay, that is this year only. And we celebrate it with the free webinar for NMT also, okay. So further, any of the institutes, if you want your batchmates or your colleagues to get benefited with a free webinar on NMT, also you can contact me on my WhatsApp, okay. And make sure that this concept, more than a concept, it has become a clinical approach. So this approach has to reach each and every person in India, because it's a made in India or a make in India approach. And also remember, I have put the email ID, okay, and the Facebook page aompt.org, okay. So number is always already given, okay. So I'll close the presentation. So okay, have you noted down my number? Okay, so because I don't think so that at least after lockdown, your own colleagues will tell, you don't have this number, what were you doing in the lockdown? Okay, so so always wish you all the very best. And I will tell one thing, the Physio Inculcators have done a commendable job. Okay, it's not easy to hold these many free webinars and communicating with different resource persons. And they are actually, it's a group of well-wishers. Okay, they have just formed an informal group. Okay, they are yet to go into the formal process of registering and then going down as a society or certification and all that. Okay, but still their work speaks about themselves. Okay, so that's the main thing which I was really impressed. And Career Point University, I know because ever since Dr. Harsh was associated with that, and after that Dr. Kanchan used to be always in touch with me. So, and now Dr. Himanshu has become another big inspiration, because we need people in the next generation to do good work. Okay, that is when the future will be better for the profession. Okay, I always believe that. Okay, if my student can be better than me, that means the future is better than past. So profession will improve, because they are the future therapist. Okay, so next generation we should make them better than us. Okay, so tomorrow when I go for treatment, my student can treat me better. Okay, if I don't share my knowledge, who will treat me tomorrow? I will never go to a physiotherapist. Okay, because they will do osteopathy. Okay, I will become afraid. Okay, so always remember, learn the physiotherapy techniques properly. The best of physical therapy, learn it to be the best physical therapist. Okay, before telling that physiotherapy is useless, you check yourself whether you have learned it fully. If you use it fully, it is useful. If you use it less, it will be useless. Okay, so with that closing words, I wish everybody the best of luck. Enjoy the lockdown as long as it lasts, and don't allow the spirit of learning to go down because of any reasons. Don't tell reasons. Okay, there should be only one purpose, that the best knowledge. Okay, we should always keep improvising. Okay, and try to get more questions. The more and more you question, more the knowledge becomes better. Okay, so don't be hesitant for that. Okay, if you are learning from my lecture, I learn from your questions. Okay, so I always repeat this in every session of mine. Questions, I might react the way the questions are worthy. Okay, sometimes the questions will be funny. Sometimes the questions will show that you have a huge traffic jam. Okay, so I might laugh, or I might jump, or whatever I do reaction, it is my way of doing it. Don't think that question is right or wrong. Only answer can be right or wrong. Okay, and students, moment we tell question, they get afraid. Exam. Okay, okay, dar lagta hai. So remember that, don't create a stigma for the exam. Okay, exam is part of the degree. The real exam is every patient who comes to visit you. They are the examiner. Okay, so when you are a clinician and you are able to show the result on the patient, okay, that is the thing there. So one patient has improved does not mean you are an expert. next examiner will come, okay, immediately. So being the best clinician is actually being the best physical therapist, okay. And how you will be a best clinician is by always being a best student only, okay. You learn from every patient, and you learn from colleagues, you learn from your experiences, and you would also learn from each other, okay. So that learning should never end. As long as your brain is alive, you can prove that it is alive only if you have the ability to learn, okay. If you feel that I know everything, that moment itself, your brain is dead, okay. So don't go by that. And closing remarks will be given by Dr. Himanshu again, okay. Good luck to you all.
Thanks a lot, sir.
Yes, Dr.
We are
Himanshu.
really much grateful to you. Even though I don't have words to express my gratitude, my sincere gratitude to you. And today, even my routine dialogue is also fails that I used to say, yes, we had maintained 100% attendance throughout the session. But here I can see we had started with the 40 participants only. And we are, even though right now having 60 participants, in between we had 74. So this is the aura of your talk. And this actually what the Senthil Kumar sir is. So this was a really awesome session. We had a great learning, great practical learning, even though I would say personally, there are 2-3 practical doubts I do have. I may have studied in the books, but never practiced. So today I would like to mention even Tinel sign. I have ever read it, रट लिया था, लेकिन literally I just seen it first time here. So it will definitely improve our clinical practice. And
especially the interpretation, okay, that local positive versus distal positive,
yeah.
That difference, and then nerve massage, okay, which commonly we don't get access to that information anywhere. Yeah.
So this is
Continue.
really hats off to you, sir, and means it is even we are blessed to have you with us, and it is really a matter of honor that we can hear from you. We can learn directly from you on this topics, on this area of your expertise, your great expertise actually. And if you allow, sir, I think there was 1 or 2 questions in the chat box, and lots of great.
Yeah, sure.
Okay, sir. Thank you, sir.
Dr. Vidhi. Dr. Arun sir.
Arun Balasubramaniam sir is
Professor
also.
Arun sir is another inspirational role model for all his students. Okay. He's working now in a government establishment, okay, clinically, but he was a professor for so many years. So great experience. He's also my UG batchmate, okay, my BPT batchmate, Dr. Arun Balasubramaniam sir, who's one of the participants here. He's hiding behind. I don't know whether he's really watching. Initially, I saw him leaning on the sofa. I think he slept now.
Sir, there is one query in the
Okay.
chat box. Can you go ahead, or should I narrate it for you?
Yeah, please narrate.
Yeah. Thank you, sir. Thanks a lot.
Are there the questions are there in the chat? Is it
There's one
public?
question, I think. Shall manual therapist be able to move the vertebra?
Wait.
By Justin Justy.
Is it there in the chat? Yeah, one question is there. Entrapment neuropathy and compressive neuropathy.
Yeah.
Yeah, manual therapist able to move the vertebra.
Yes, sir.
Okay. See, remember, what is this moving the vertebra means? You are supposed to be correcting the position of the vertebra. Okay. Remember that vertebra always moves. Okay. Thoracic spine moves less. Sacrum is fused so it will not move. Okay. The topic is not spinal mobilization, but still you remember that you can always correct the movement of the vertebra. Okay. As a physical therapist, if the vertebra is not moving, can you make it move? Okay. Yes. If it was previously moving vertebra, which is now not moving, you can make it to be moving. Okay. Previously itself, it was not at all moving vertebra like sacrum and all, you cannot mobilize. Okay. So remember that you are moving the vertebra does not mean you are moving it somewhere out of the spine. Okay. You are moving it within its anatomical range of motion. Okay. Every joint is movable. Okay. Be it sutures. Okay. Even that spinobasilar junction, which is inchondrosis, fibrocartilaginous joint, is also movable. Okay. So you see for synovial joints, definitely movable. Intervertebral disc is inchondrosis, fibrocartilaginous. So that is movable, intervertebral disc. Okay. And then next one, facet joint is synovial joint, plain synovial joint. So both are movable joints. So spine has to be movable. If spine is not movable, my head, I'll be like a Robo 3.0. Okay. So remember that. So because I'm having the movement only, it is there. So same way you can do the movements for the spine. Okay. You don't have to be an expert manual therapist for that. But remember that the movement which you are trying to do should correlate with the movement that is affected and the movement that is involved with the functional impairment. Okay, patient is not able to do a particular functional activity. For example, I am not able to read or text for longer time like this in this position. That means the movement is flexion. So there I will try to increase the flexion. Okay, so that should be the ability. Okay, when you are reasoning out pathomechanically. Okay. There was another query that entrapment neuropathy and compressive neuropathy. Come on, both are same. Okay. So there is no complication in those terminology. Okay. Any other queries? See, that is what I am telling. If, for example, there is a two ways to teach. One, you teach in a way to make it very, very complicated, so that after your session, everybody feels that, okay, oh, sir knows so much. आपको क्या पता? अभी कुछ समझ में नहीं आया, but काफी कुछ है. Okay? तो क्या करोगे सीखने के लिए? वर्कशॉप अटेंड करो, सीखो. Oh, ठीक है. That is complicated. Simplifying is you make it like, you know, anybody can understand, anybody can generate a new technique, and they can understand, apply also on the patient. Okay, simplifying. When you simplify, sometimes the new beginner will think that, okay, I can use it on everybody. Okay, yes, you can use it, but make sure that your hands are not using it. Before that, understand from the heart the suffering of the patient. Okay, empathy, and plan from the mind. Okay, that am I doing it correctly? Okay, these two, then your hands will do justice, because that is the decision of him to make you a physiotherapist. Okay, so that's the blessing that you have. Okay, so don't try to take things for granted. Okay, and also never blame another physiotherapist. Okay, for any reason. If one therapist has treated, the patient is not improving, and then the patient comes to us, don't tell that what the previous therapist has done. Okay, then patient will go out and tell what this therapist is telling about that therapist. Okay, so remember this ethics also, which is very, very important. Clear? You show your strength in your performance. Okay, don't show your strength in your words. Okay, and any more queries do we have? Yeah. Treatment plan for carpal tunnel syndrome. For the treatment plan for carpal tunnel syndrome, buy the video from AOMPT. There's an extensive video for carpal tunnel syndrome. Okay. How to fix uneven shoulders. Because you are asking a structural fault. Okay, uneven shoulder. That means what? You want to tell whether my left shoulder is depressed or right shoulder is elevated. Which one you want to correct? Okay, uneven shoulder is not at all a condition. Okay, you have to see in terms of whether neck pain is here or shoulder pain is here. Okay, which is the problem, and who is having, whether it's a child who is having uneven shoulder, whether it's the elderly who is having uneven shoulders. Patient is important. Patient को कुछ भी पता नहीं, और डिस्फंक्शन जो सिम्टम्स है पेशेंट का प्रॉब्लम वो भी पता नहीं, सिर्फ शोल्डर को क्यों करेक्ट करना? अनइवन है तो इवन करना, यही है ट्रीटमेंट. बट ये स्ट्रक्चरली ट्रीटमेंट करके क्या होने वाला है? ओके, अपना नानी को देखो, दादी को देखो, उनका शोल्डर इवन नहीं, वो ऐसा रहेगा. उनका गर्दन का पेन भी नहीं, शोल्डर की पेन भी नहीं, बिल्कुल एक्टिव है. हम लोग सो जाते हैं दिन में, वो लोग तो 3 बजे 4 बजे उठ के उसके बाद पूरा काम करते रहते हैं, लगातार लगे रहते हैं काम पे. How that 80 years, that old lady who's having so much of kyphosis, you take an X-ray, so much of degeneration, okay, but absolutely fully doing all the household activities, taking care of everybody. So don't go by structural fault, okay, go by the functional, the dysfunction and the symptoms, okay. All of us have hamstring tightness, all of us will have neck muscle tightness, okay. If you don't have neck pain, we are normal, okay. So our body may be adapted and it is absolutely normal. You need not treat everything. You treat only one thing that actually is causing the dysfunction, and then pathomechanically involved with the functional activity that is reported as a patient symptom. Okay, I am not able to do this particular activity. Like that. Don't tell that nobody answered. It is because the question is like that. Okay, it is like asking how to see the sun. Okay, what will be the answer? Maximum we can tell, दिन में बाहर टेरेस में जाके छत पे चले जाओ और उसके बाद आंख खोल के ऐसा ऊपर देखो, ऊपर नहीं है तो राइट साइड देखो या लेफ्ट साइड देखो, इतना ही बता सकते हैं. क्योंकि कैसा, how will you watch the sun means, okay. So remember that it's unevenness does not mean that it is abnormal. That is what I want to keep making you understand, okay. So don't think that uneven shoulder is an abnormality, okay. So scar tissue compression, every stage. See, in if there is a scar tissue and there is a compression neuropathy, when to use the neurodynamics, okay. Any stage you can use the neurodynamics. I have started from continuous symptoms where you offload, okay, to intermittent symptoms where end range, where you are going to give a tension technique. Okay, I have shown the full spectrum and also shown myofascial and articular. That's why I said buy the NeuroManual therapy videos. It will be worth for you to learn. Okay, if you are having interesting queries. Okay, because it's not that costly and you are going to definitely get a best what is called as a path ahead. Okay, so be it leprosy or be it diabetic neuropathy, okay, whatever the condition, remember that physicians treat the disease, so don't go by the disease. Physical therapist treats the dysfunction behind the disease, okay. So an orthopedician prescribes a pill for low back pain. Physical therapist treats the facet joint dysfunction for that low back pain. Physical therapist treats the myofascial imbalance for that low back pain. Physical therapist treats the neural mechanism sensitivity behind that low back pain. Okay, so remember that dysfunction is more important, not the disease. Okay, be it stroke, hemiplegia, you can give neuromobilization. Radiculopathy, you can give entrapments, you can give cut injuries, you can give. Okay, don't think neuromobilization is only tension techniques. Okay, I have told you about slider techniques. I have also told you about nerve massage. If you explore graded motor imagery, everyone who has brain can be given. Okay, so there is absolutely no contraindication at all for graded motor imagery. Okay, so these are all techniques which you should add into your what is called as toolbox, so that physical therapy treatment techniques they are. Okay, so you should be the best as a physical therapist by knowing all this. Okay, so we're ready to get the closing remarks, so we can wind up this session, extended session today. And I wish the team Physio Inculcators the very best also. And as per you feel that even any other better techniques you want a suggestion also, AOMPT, we take courses of around 70 topics. Okay, and of course many new techniques or approaches are registered under the AOMPT. So a lot of videos and lots of courses. We have anatomy, biomechanics, physical examination and differential diagnosis videos. AOMPT also has manual therapy for all the regions, all concepts videos. Okay, arthro, myo, neuro, manual therapy. Okay, an integrated approach, simultaneous approach of articular, myofascial, and neural, all the regions. So it's you name it, it is there. Physical therapy for any condition, frozen shoulder, ankylosing spondylitis, therapy, all conditions, carpal tunnel syndrome, coccydynia, everything is there. Okay, videos are there. So which will be really useful. That you take it either as part of a package, okay, or you take it regionally, okay, or disorder wise, okay. So either way, which will help your knowledge definitely. Okay, all the online courses are 5-star rated, and I'm happy to know just after this lockdown, during this lockdown, the huge achievement that more than 5,600 followers are there in AOMPT Facebook page, and this is the only academy on Facebook in the Facebook page rated 5 out of 5 stars, where more than 5,000 followers are there. Okay, so it's people have done the courses, they have put the reviews, and there are members like Dr. Ritu, Dr. Vidhi. They are all very proud members. Dr. Ritu has listened to my lecture so many times. NMT she has listened to 4 times. Okay, why she's attending 5th time? Don't think that she is not understanding 4th time, so 5th time she's there. No. Okay, if you are a passionate learner, every time you will learn extra. Okay, same textbook when you learn itself, first time when you read and second time you read, you will learn more. Okay, so this is what happens. Okay, that is because your sincerity to learn, showing it more and more, knowledge comes to you. Okay, extra. So this happens, and so always remember, keep improvising your knowledge, competing with yourself. Okay, compare with yourself only. Don't compare with another therapist and see that he is knowing myofascial techniques. Okay, I also should do something. Okay, not like that. Okay, so you should see in terms of how I was last week, how I am now. Am I getting better compared to myself? Okay, so that will be the best thing, because there is nobody who deserves to be compared to you. You know that only person in the mirror also, you know that it is not you. Okay, because it's showing opposite. Okay, in the mirror. So then why you are comparing with the other people? You are so precious, you are so unique. Okay, and how can you say that somebody else is comparable to you? Okay, so always compare and compete with yourself. Okay, that will have you peace of mind. And whenever negativity is there, the only way to combat it is by smiling, wishing that negative person the best of luck. Okay, try your level best. Because you have negativity, you want to attack me, no problem. I have positivity, I don't have to bother. Okay, so that kind of reaction you should give if somebody is trying to pull you down. Okay, and it's like the simple proverbs are there. You might have heard that quotes that don't tell God that I have problems. Okay, I have this problem, I have that problem, I have that problem. Tell the problem that I have God. Okay, so this is the change of perspective. Okay, same way, I used to tell that if somebody is pulling your leg pulling, tongue kichna. Okay, if they are pulling your leg, it's because they are at your foot. Okay, so they will pull the leg only. Okay, so don't think that they will do anything better. Okay, if somebody is backstabbing, why they are stabbing at your back? Because they can't face you from the front, man. So you pray for them. Pray God that इनको थोड़ा हिम्मत दे दो, मुझे सामने से आगे आके मुझे सामने करे. Okay, so like that you should have that attitude. It's not ego, it's a self protection. Okay, you don't allow negativity to affect you. Okay, that way you try to see. When you feel that you are precious, that is self image. Okay, which is good. But if you feel that you are only precious, that is ego. Okay, so that's the difference. Okay, or if you feel others are cheap, okay, that is super more what is called as you are not eligible to be a human being. Okay, if you feel like that. Okay, so don't think to suppress others. Okay, if you can't encourage others, be silent. Okay, and just ensure that life will give the best automatically to you. Okay, however late it is, but it will come the best. Okay, so good luck to you all. Okay, and keep
Sir, thanks a lot
rocking.
for your best wishes, and really we have a lot of learning from you in this session today, and we are fortunate enough to learn from you, and we'll definitely try to approach you for more learning in the future, so we can become even much better than yesterday and for the coming tomorrow. And thanking you for your kind words and for your blessings and best wishes. We'll try to keep moving ahead, try to become much better than yesterday. Thanking you, sir. Thanks a lot. Uh,
Okay.
Much sincere gratitude to you. And at the last, I have information to the all participants that we'll meet again on the next Friday at the 9 p.m. For the discussion, for the learning on a very good topic, maybe a basic, but I think, as I think it is underused techniques, interferosis in physiotherapy. So many of us may have studied during graduation, but we are not even practicing. So we are trying to explore the interferosis practically more. So be with us. Let us stay tuned with us. We'll meet again at next Friday, 9 p.m. Thanking you all, and much grateful to the Senthil sir for sparing their precious time, because they are still busy in the conference right now. Still they have spared the time. So hats off to you, sir. How you do this? I can't even imagine it. How much dedicated you are for the profession. Thanking you, sir. Thanks a lot. Thanks to all the senior participants who joins us, and my faculty members, teachers, and mentors. Thanking you all, and stay tuned, stay safe. Good night.